first prize in clinical poster presentation at ESI 2001 in Mumbai. She's been a part of many publications, a lead author for management of diabetes in Hajj, a co-author for risk stratification during Ramadan, and also for the Dire Ramadan study. And she has research interests in obesity and its prevention, osteoporosis, and structured diabetes care. A very warm welcome to you, ma'am. It's a privilege to have you with us today.
Thanks, Aditi.
And it's my honor to invite our next chairperson for today's session, Dr. Pankaj Agarwal, sir. He's a consultant endocrinologist at Hormone Care and Research Center, Ghaziabad. He's a founder of the Medical Concepts in Hindi, which is an attempt to bring modern medical science in our own mother tongue, that is Hindi, and also involves online classes on integrated endocrinology for PG and UG students in Hindi. Sir has been a principal investigator in 29 global and 5 national studies and has around 26 publications in international and national journals. He's also a university examiner for DM endocrinology. A very warm welcome to you, sir. It's a privilege to have you, sir.
Thank you. Thank you, Dr. Aditi.
Over to ma'am and sir for the next session. And I would request Shaila ma'am to please invite our first speaker. Shall I share the CV, ma'am?
Yeah, please, Aditi. Thank you very much. I think very, very pertinent topic and very, very important topic, because we increasingly need to change our mindset when we are looking at our geriatric patients, which are actually increasing by the number. And it gives me great pleasure to introduce somebody who is actually doing it. So we have Dr. Naganath Narasimhan Prem, who is at present the founder, head and chief consultant of geriatric medicine, elder care specialist at Jaslok Hospital and Research Center, Mumbai. His major objectives are to create a strong framework for holistic elderly care through comprehensive multidisciplinary assessment and interdisciplinary interventions. Passionate about teaching, academics, and research so that we can have evidence-based care for the older patients. Areas of interest include geriatric syndromes, dementia, orthogeriatrics, geriatric oncology, chronic care, and community geriatrics. He's also a leader in the Graceful Living Initiative. And as I said, he's established the first department of geriatric medicine in South Mumbai at Jaslok Hospital. Has the first ever support group for older adults at Jaslok Hospital, multiple presentations, and several book chapters. It's going to be a pleasure to listen to his talk. Over to you, Dr. Prem, please. Prem, we can't hear you. You're muted.
Sorry. Thanks a lot to Endocrine Society of India to actually invite me. A special thanks to Vinod sir and Dey sir, actually, who actually have played a very important role in my formulation, because I was in AIMS before I came to Bombay. And thanks a lot, Dr. Sheikh, to actually introduce me. It's a very honor to be in this particular gathering. I'm not very sure if I can share my screens. I'm not a host. So I could.
You would be able to share it. Screen sharing is open at this point of time.
You can share.
I can share it. I hope you can see my slides.
Yeah, we can.
Okay, so for the better part of most of last year and to still this particular time, we have been talking about a pandemic, which obviously everybody has fought, but always we have been fighting with the big D, that is diabetes, along with a very important pertinent O, which is osteoporosis. So osteoporosis in people with diabetics, especially the dual pandemic in older adults, I think that is something which is very important. As we all know that it is increasingly prevalent in the aging population, and in type 2 diabetes mellitus, it has been seen that the vertebral fracture risk is increased. If fracture risk is increased both in type 1 as well as type 2 diabetes mellitus. Now, as far as risk factors for fractures are concerned, one is of course increasing age, the lower BMD, lower BMI and high BMI both, but lower BMI more so. Falls, I think falls is something which as a geriatrician I'm very, very worried about, because ultimately that can cause very significant decline in quality of life. The duration of diabetes, I think the number of years that the older adult is actually having diabetes The complications. Now, the complications, which include many-fold, can be a significant risk factor for fractures. Now, as far as microvascular complications are concerned, especially, I think sensory neuropathy, retinopathy, and visual impairment, they affect a significant part of an older adult, that's the vision. So there is an increased risk of falling. And when there is an increased risk of falling and fall-related fractures, it has been seen very highly in older women with diabetes. However, it has also been seen that men who fall have a more chance of having increased mortality and morbidity as compared to women. Then neuropathy also causes localized bone loss, which might increase the risk of fracture, especially the foot and ankle, which I think one of the two important joints, especially for a person who has been mobile and then suddenly becomes immobile. So it affects, I think, a pertinent quality of life, which I'm very, very concerned about in an older adult. If you have to look at the pathophysiology, I think there is, of course, reduced bone formation, osteoblast dysfunction, and low bone turnover. Now, as far as type 1 diabetes mellitus is associated with decreased BMD, in type 2, which is most commonly seen, of course, in older adults, is frequently increased or normal. So BMD might not always give us a good idea. And pathophysiology, of course, is multifactorial. So I will get to it sometime. In type 2 diabetes mellitus, as we know, there is an accumulation of a huge number of inflammatory cytokines. So when there is hyperglycemia, that is chronic increased glucose levels, the bone matrix glycation happens. It will impair the collagen turnover, matrix renewal, and ultimately end result is impaired bone formation, more fragile bones, which are actually having advanced glycolated end products. And then this causes alteration of the bone structure. Ultimately, osteoclast function will go, blast function will go, more bone marrow adiposity happens, and more inflammatory cytokines, and ultimately the osteocytes decrease in number and function. So the quality, so we are saying that the bone structure is affected, the quality of the bone will be affected, and ultimately the bone matrix it becomes very stiff, and the material properties leads to more of brittleness and mechanical failure, especially when you are put on physiological levels of stress, which is as basic as just walking. Now, as far as the effects are concerned, I would pertain more to type 2 diabetes. One is the pathology, as we know, is insulin resistance, hyperinsulinemia, raised IGF-1, and raised blood glucose. Onset in older, usually maturity onset. As far as the BMI is concerned, it's usually on the higher side. There might be an increased load on skeleton. It can be protective against an impact, of course, as far as osteoporosis and fall is concerned, but increased estrogen, leptin, and ultimately adiponectin production in adipose tissue will happen. Hyperglycemia again can cause increased urine calcium loss and inhibit bone formation. Bone turnover becomes low. And as I said, AGE products may affect the fragility. And there is, of course, an anabolic effect of insulin resistance. Now, as far as BMD is concerned, it might be normal or might be increased. So that doesn't really give us a very good idea. Fracture risk is definitely increased. I will also come to the drug chart, but usually fracture risk reduction is there with metformin, and it is increased with triazolidinones as well as SGLT2 inhibitors. Insulin again might have an anabolic effect, but use obviously shows that the diabetes has been long standing and it is a severe disease. So we know that the person might be insulin dependent by then. As far as medications are concerned, yes, medications anyways play a big role in older adults. And if medications are causing that particular fracture risk, then even more so. So as I already mentioned, as far as triazolidinones are there, so they cause decrease in BMD and distinct increase in risk of fracture, and to an extent even SGLT2 inhibitors might cause. Others are comparatively safe. Metformin might actually increase the BMD, and it might have no change or decrease the risk of fracture. As far as assessment is concerned, I think fracture risk assessment in person with type 2 diabetes mellitus is important. Lower BMD is predictive of fractures in type 2 like the general population, but the excess fracture risk which is there will not be captured by BMD, which is paradoxically higher. So it does not account for differences between the type 2 diabetes mellitus population with osteoporosis and the general population. Then the second thing is there is of course increased cortical porosity. So research shows that high resolution peripheral quantitative CT will show a deficit in the cortical bone, which will resulting in increasing the porosity and increase in the fracture risk. Explaining, of course, part the reduction of bone strength, which again will not be shown in DEXA. Now, as far as FRAX is concerned, the risk of fracture may be higher in patients with those compared without diabetes. However, the algorithm of FRAX will not have diabetes as a risk factor does not. So the TBS score can be used in these patients. What is the TBS score? This is where the bone microstructure comes in. The trabecular bone score, it is basically an index of the bone micro architecture derived from the lumbar spine DEXA, and it serves as an indirect measurement of the trabecular bone quality. Now, adults with diabetes who will have a lower trabecular score as compared to individuals with normal glycemia. So it will help us in being a significant predictor of fracture risk independent of the bone density as compared to FRAX, which will not really tell us exactly, and BOMD also to an extent won't. Now, as far as management is concerned, most of the research very clearly says that anti-resorptive agents are the first line of therapy in anti-osteoporosis treatment, even for people with type 2 diabetes. If I have to just mention some trials, one is of course the FIT trial, that is a fracture intervention trial. It was a trial of 6,450 women aged 54 to 81 years with lower femoral neck BMD. So the conclusion was anti-resorptive therapy, in this case it was alendronate, was as effective in type 2 diabetes mellitus as in those without diabetes. However, the study was underpowered to compare the fracture outcomes. Now, Anagnostis and his colleagues in a systemic review concluded in another review that presence of diabetes does not alter any osteoporotic treatment regarding especially the BMD increase or the vertebral fractures. So there was no particular difference. Then the Freedom study, which I had around 7,808 postmenopausal women, in which 508 with diabetes received denosumab, and out of which that is 266 and 242 got placebo. So overall, this also showed that denosumab significantly increased BMD and decreased the vertebral fracture risk in subjects with osteoporosis and diabetes, but there was no reduction in non-vertebral fractures. Then other study, which was known as the active one, that is abaloparatide comparator trial in vertebral endpoints, which was done by Dhaliwal and colleagues. They analyzed this. So it was basically a phase 3 double-blind randomized placebo and active control trial in which 198 women with postmenopausal osteoporosis and type 2 diabetes in 21 centers in 10 countries were taken. Now, despite the small number of subjects and fracture events, there was a significantly fewer non-vertebral fractures in patients with type 2 diabetes treated with abaloparatide versus the placebo. Now, if you have to see in basic how we would want to do a fracture risk evaluation, one, if a person with diabetes has a hip or a vertebral fracture or more than one other fragility fracture, then osteoporosis therapy has to happen. If the person has other fracture, then we have to do a DEXA, a vertebral fracture assessment, and a TBS if possible. Vertebral fracture assessment really has not shown a significant sort of help, especially in a person with diabetes. If there is no fracture, of course, we have to look for diabetes specific complications, CRF, or if age. If there is no other particular thing, then yearly clinical assessment is what we need to do. However, if the person has another fracture and we then do the DEXA with a T-score of -2, then osteoporosis therapy, and or the FRAX, which we need to do. Again, we have to see the specific intervention threshold. The point here is ultimately we need to see that we might have to repeat DEXA and FRAX every 2 to 3 years. DEXA availability is very important, and I think that is something which we need to sort of think. Older adults accessibility to particular doing DEXA also is another important thing. So I think the most important take home points here would be both diabetes and osteoporosis are increasingly prevalent diseases in part owing to aging populations worldwide. Secondly, there is an increased risk of fracture, particularly marked at the hip in patients with type 2 diabetes mellitus, which is much greater than expected based on BMD decrement, implying that there are other BMD independent factors also. So we should not only look at the bone mineral density, things like microvascular complications also need to be taken into consideration. Then anti-diabetic medications, which I already mentioned, may contribute to increased risk of fracture and diabetes. Then anti-resorptive agents are currently the first line therapy for anti-osteoporosis treatment, although anabolic agents may be preferred if there is a very high fracture risk. Now, selecting an agent with demonstrated efficacy for hip fracture prevention is important, given this is a very high risk group anyways, and a high risk for hip fractures in type 2 diabetes mellitus. So select your drug, make sure that the person is under follow-up, and also DEXA is particularly done. And in older adults, I think one of the most important things is to please explain the therapy clearly to them, and maybe ideally to another caregiver. And falls is one of my biggest concerns, because when we do not discover osteoporosis and not treat osteoporosis in older adults, it's bad. Older adults with type 2 diabetes mellitus, it might have even more fatal results. So thanks a lot for your patient hearing.
Thanks, Prem. I think you brought that out very well, that, in a busy consulting, we tend to only look at BMD and interpret our patient's fracture risk according to the BMD. And I think a very, very important pertinent point you got across was that diabetes with osteoporosis, especially in our elderly patients, can potentially be a very, very big issue and needs to be preempted and tackled accordingly. I'm sure there are lots of questions on this frame, so I won't waste too much time. I'll hand it over to Dr. Pankaj to introduce the next speaker, and then possibly we can have a discussion at the end of all the talks.
Thank you.
Thank you very much, Prem. That was really fantastic.
Dr. Pankaj, we cannot hear you. If you could unmute.
Oh, sorry. So good evening, friends. And it's my privilege to introduce a towering personality like Dr. Ravi Kant, who is additional professor and head division of Diabetes and Metabolism Department of Medicine, AIIMS Rishikesh. He is president, secretary, and joint secretary of various associations in Uttarakhand or all over India. He is editor-in-chief for the Journal of Cardio-Diabetes and Metabolic Disorders. He is executive editor for Current Diabetes Review. He is editor for so many other journals, Journal of South East Asian Medical Clinics, quarterly print journal International Journal of Obesity and Weight Loss Therapy, the Open Alternative Therapy Nutraceutical Journal, Journal of Internal Medicine of India, and so many others. He is expert for Initial Screening Committee of Department of Science and Technology, India, for building world-class biotech GMP manufacturing facility for bulk insulin or insulin analog facilities based upon the in-house developed recombinant DNA technology. Dr. Ravi Kant, a well-renowned person all over India, he will be speaking on a very pertinent topic, dementia and diabetes, a topic which is more of an abstract one, difficult many times to understand what is dementia, whether this patient is suffering from dementia or not, and if at all we find it, what to do, how can we intervene to give a positive outcome in that patient. So with these words, I welcome Dr. Ravi Kant and request him to start his session. Dr. Ravi Kant, please.
Thanks a lot, Dr. Pankaj, and thanks the organizers and Dr. Nitin for inviting me. And I'm just going to share my slides. Are my slides visible to you all?
Yes, please. Go ahead.
Fine, thank you. So at the very outset, I must congratulate for holding such symposium, since I have been associated with geriatric care for such a long time, as my postgraduate thesis was in geriatric. So I had a very close association with the people of geriatric age group, and I can very well understand the evolving medical science in this particular arena, which of course is the requirement of the time. So I shall be talking about diabetes and dementia, a dual danger, and in few next minutes I shall be dealing with the definition of dementia and how is it related to diabetes mellitus at all. So I shall be going through the definition, mild cognitive impairment, and dementia of Alzheimer's type, risk factors associated with dementia, and the diabetes along with cognitive decline associated with diabetes mellitus, pathogenesis of dementia and diabetes, and of course a few words about management strategies. Now, how to define dementia? The term dementia is basically a Latin word which means devoid of the mind. Denotes a deterioration of intellectual or multiple cognitive functions with little or no disturbance of consciousness or perception. It is basically a syndromic approach and characterized by failing memory, impairment and deterioration of the intellectual functions, and certain behavioral abnormalities along with changes in the personality. It's often is because of chronic progressive degenerative disease of the brain. Now, DSM-4 criteria for dementia that says that the cognitive deficit must reflect a decline from a previous higher level of functioning. So it's very important to know the previous cognitive level of the person from a close aid or family member or care provider. It should be sufficiently severe to cause an impairment in occupational or social functioning. This is important, and of course, with the core diagnostic criteria of aphasia, praxis, nausea, and disturbance in executive functions. Now, what is important is to realize the mild cognitive impairment, which of course is the accompaniment of geriatric age. This is basically defined as a mild memory, impairment that do not interfere with the daily functioning, but are still disproportionate for the patient's age and education. There is something called age-related cognitive decline, or sometimes known as mild age-related cognitive decline, which is very common in geriatric population. As the age advances, their mild age-related cognitive decline takes place. But mild cognitive impairment is pathological, not totally dementia, not perfectly they are all right, but they do have interference with the daily functioning, but doesn't affect the gross areas of life. The condition has been called a mild cognitive impairment, age-associated memory impairment, or benign senescent forgetfulness. So mild cognitive impairment as per DSM-5 is defined as a disorder that does not interfere with capacity for independence in everyday activity. The elderly people are independently doing their ADL and IADL, but in dementia they are not able to do it independently. What is the significance? 50% of patients with mild cognitive impairment develop Alzheimer's disease over 4 years. That is approximately 12% per year. That is why it's very important to catch this entity as early as possible by giving adequate time to geriatric population in assessing their higher mental functions and of course the intellect. It is estimated that 15% of the population maybe experiences mild cognitive impairment if we assess this geriatric population in a methodical manner. Now, there are various types of dementias like cortical dementia and subcortical dementias. I will not be going much into details, but the most important cortical dementia is Alzheimer's type. What is Alzheimer's type dementia? Basically, AD typically starts with recent memory impairment, then involves the language, and visuospatial and executive dysfunctions are there. So these patients, they have an zognosia and apraxia. In the early stage, they have episodic memory loss, category generation, and at the later stage of the Alzheimer's disease, they become rigid, mute, incontinent, bedridden, needing assistance with activities of daily living. So this is a coronal T1 weighted image of hippocampus in Alzheimer's disease. You can see that there is a progressive loss of volume as the disease advances in dementia of Alzheimer's type. Basically, if you look at the FDG PET, there is hypoperfusion or hypometabolism in posterior temporoparietal cortex. Why I'm dealing so much in detail of Alzheimer's type? Because this is the most common type of dementia in diabetics as well. There's something called amyloid angiopathy, leads to accumulation of beta, chains in cerebral arterioles. And if you look at the pattern of involvement, the earliest signs that are seen are medial temporal lobe and hippocampal involvement. Later on, lateral temporal cortex is also may be involved. So let us come to the cognitive decline in diabetes after discussing what is mild cognitive impairment, what is Alzheimer's disease. Cognitive dysfunction in diabetes mellitus can manifest itself as diabetes-associated cognitive decrement, mild cognitive impairment, and dementia. So it is a continuum of disease right from normal person to diabetes-associated cognitive decline, mild cognitive impairment, and dementia. So it is very important to assess your patient right even when they have not attained the geriatric age group, that is 60 years. These patients of diabetes mellitus have frequent forgetfulness, starting as early as in the 4th decade or maybe in the 5th decade. The mechanism of MCI and dementia in diabetes have mainly been studied in patients with type 2 diabetes mellitus and involve mixed vascular and neurodegenerative pathologies. This is often on a background of Alzheimer's disease. So sometimes you can get frank Alzheimer's disease, sometimes you can get early cognitive decline in diabetes, sometimes both may coexist together. So the pathophysiology, if you look at the type 2 diabetes mellitus where we have insulin resistance, this leads to accumulation of beta amyloid, and this is vice versa reaction as well. More beta amyloid means more insulin resistance, and this vicious cycle keeps repeating itself, leading to a loss of neurons as well as leading to temporal type of dementia. So advanced glycated end products, they are of course accumulated in the vessels as well as the soft tissue. There is increased pro-inflammatory cytokines that leads to aggravation of dementia, and of course metabolic obesity syndromes along with hypercholesterolemia are other contributory factors in this disease. If we look at the association between diabetes incident Alzheimer's disease in the whole study population according to previous cardiovascular disease, sex and onset of age of diabetes mellitus, which is adjusted for cardiovascular disease, and if we look at the Alzheimer's disease, the odds ratio is always high in patients with diabetes who develop in the midlife as compared to late life diabetes, all mild age-related diabetes. So type 2 diabetic patients are at very high risk of developing dementia over years. And of course, males they have higher propensity as compared to females. If we adjust for the cardiovascular, even we do not adjust for cardiovascular, this population is of course having a high propensity of developing Alzheimer's dementia. There is accelerated progression from mild cognitive impairment to dementia in people with diabetes. If you look at the graph, you will find that after mean follow-up of approximately a year or so, the two population becomes divergent, and subjects with pre-diabetes or diabetes, they have higher or accelerated development of dementia from mild cognitive impairment. So there is approximately 12% of Alzheimer's disease who have diabetes mellitus as compared to 10% controls. People with Alzheimer's disease were more likely to have diabetes mellitus than matched controls with odds ratio of 1.14 even after adjusting for CV diseases. So this is the graph which is already discussed. So if we look at the diabetes and dementia systematic review, the incidence of any dementia was higher in individuals with diabetes than in those without diabetes in 7 of the 10 studies reporting this aggregate outcome. The high risk included both Alzheimer's disease and vascular dementia. So 8 out of 13 studies and 6 out of 9 studies, they have conclusively proven that yes, of course, the dementia is high in diabetic population. And the risk factor for cognitive decline, of course, are poor glycemic control. Hypoglycemia is very, very important in geriatric age group, and hypoglycemic episodes. Age, obesity, depression, smoking, dyslipidemia, and vascular complications are other contributory factors. What is very, very important is hypoglycemia and poor glycemic control over years. So this is how the pathogenesis takes place. Those patients of type 2 diabetes mellitus, they have impaired neurogenesis. Blood-brain barrier dysfunction is, of course, existing. Inflammation, hyperglycemia, insulin-resistant vascular dysfunction. They all lead to acceleration of Alzheimer's type dementia pathology. Ischemia and other mechanism leads to cognitive dysfunction. So comorbidities and polypharmacy, medication, genetic predisposition, and of course, accompanied with glucotoxicity, hyperinsulinemia, microvascular disease, and atherosclerosis leads to vascular dementia at one end and Alzheimer's dementia at other end. Along with aging, this leads to a complex syndrome of dementia in diabetics in geriatric population. So insulin is, of course, toxic. Hyperinsulinemia has been identified as a risk factor for accelerated cognitive decline in dementia. So these patients with dementia and diabetes mellitus, they have hypothalamic pituitary adrenal axis hyperfunctioning. And this hypercortisolism, of course, is considered as a risk factor for cardiac disease as well as the dementia. Now, how to combat this problem? What can be done to reduce the development of dementia and diabetics? Of course, the answer is better control of diabetes mellitus, avoidance of hypoglycemia, and treatment of concomitant depression is very, very important, which accounts to approximately 50% of geriatric problem past 60 years. Now let us look at the effect of intensive glucose lowering on brain structure and function in people with type 2 diabetes mellitus. So the participants were principally geriatric age group with type 2 diabetes mellitus and high HbA1c, concentration more than 7.5%. So the digital symbol substitution test score at baseline and 20-month and 40-month and total brain volume were calculated by MRI as a primary brain structure outcome. Now, what was found? There was no significant treatment difference in mean 40-month DSST score, but the intensive treatment group had a greater mean total brain volume than the standard treatment group. So it paved the way that if you have a good glycemic control over chronic or long-term duration, these patients, they preserve the brain volume in a much better manner. And this is one of the preventive strategy for developing dementia. If we look at the hypoglycemic episodes and development of dementia, there is a linear relationship between number of hypoglycemic episodes and the development of dementia so far as hazard ratio is concerned. Whether you adjust it for age, BMI, sex, ethnicity, education, and duration of diabetes, or additionally for other comorbidities, across the spectrum, there is high risk of development of dementia as the number of hypoglycemic episodes, they increase. The workup of any patient with type 2 diabetes mellitus and cognitive dysfunction is same as non-diabetic. Behavior, mood, and personality should be assessed. Assess diabetes management support system. Always ask for serum biochemistry, thyroid, vitamin B12, which are reversible causes of dementia. Of course, HIV and RPR as per the requirement. Neuroimaging is one of the important modality the moment you come across such patients. So you can see that the bilateral medial temporal lobe atrophy is seen in a subject with Alzheimer's disease, which is demonstrated by this white arrow. And functional MRI is showing less activation in diabetic subjects as compared to normal subjects. So this is one of the advances that we can say. Yes, we can identify the patients early in the course of the disease itself. All diabetic subjects, they have reduced functional MRI areas compared to control subjects. Now let us look what are the changes you can find in MRI of diabetic patients. So there may be white matter microstructural changes, microinfarct, perivascular space narrowing, and white matter hyperintensity, microbleeds, lectin atrophy in the later stages. And of course, the most common finding that we get in our diabetic patients is the white matter hyperintensities. Now, how to assess the patient with cognitive function? history, clinical examination, and neuropsychiatric cognitive test and relevant investigation as the cornerstone for management. The informant should be reliable. The presenting complaint may be cognitive, may be neuropsychiatric, or activities or daily living impairment. First symptoms may be memory loss, apathy, visual hallucination, or impaired mood, anxiety, maybe gait disturbances. Later on, you can get problems with short-term memory, and of course, trouble making sense of language and trouble doing familiar things. Confusion in unfamiliar places and personality changes are other accompaniment of dementia. The most important test is the Montreal Cognitive Assessment Score, which consists of many domains, and you can easily assess this rapid test for the cognitive impairment. If we look at the agreement of the MOCA and the MMSC, this is a good and sustained agreement between MOCA and the MMSC. Now, how to intervene? Non-pharmacological, you have to avoid the risk of risk factors like you have to control hypertension, dyslipidemia, and other contributory factors. Yes, of course, physical activity needs to be maintained, weight reduction. It has been seen that diabetic patients who do endurance exercise regularly, they have less chances of developing cognitive impairment. Investigational pharmacological therapy is a multifactorial. The drugs which have been shown to have better effect, although my previous speaker has said thiazolidinedone are bad for bones, but they are somewhat found to be better for dementia. They have multifactorial, beneficial effect. Targets of thiazolidinedone drugs in Alzheimer's disease, they can bind to PPAR gamma receptor and other pathways that regulate energy metabolism, cellular and animal models for Alzheimer's disease. Although not clinically tested in human being, but animal studies they have proven that it is having a better outcome in demented animals. This increases the memory of these animals when tested in animal model. So there are many more targets of OADs or injectable therapies, but they consistently have a beneficial effect in preventing dementia. That's why the importance of glycemic control, not at the cost of hypoglycemia, is the key. So insulin degrading enzyme is one more promising target for preventing or delaying dementia or treating dementia. The future only can tell what way we can develop the insulin degrading enzymes for clinical use. Now the take home message is type 2 diabetes mellitus is a modifiable risk factor for Alzheimer's disease. Diabetes has consistently been shown to increase risk of cognitive decline, mild cognitive impairment, and dementia. Diabetes is modifiable, thus disentangling the mechanisms involved may provide strategies for preventing dementia. Diabetic epidemic and its relation with dementia remains a growing concern. An indicator to review constant adherence to strict diabetic control and its long-term complications is the key. Comprehensive medical evaluation of patients to decide overall management. I believe each diabetic elderly person should not be evaluated in less than an hour or so. I think that is the minimum time that I can say is required for these gentlemen or ladies. With this, I thank you all very much for patiently listening. Thank you.
Thank you. Thank you, Dr. Ravikant, for your elaborate presentation. Learned a lot of words of wisdom from you. But to say about this cognition, dementia, Alzheimer's, it's easy for me to learn all these things theoretically, but whenever I come in front of any patient, everything is jumbled up, at least for me. I don't know about others.
Of course. That's why I said that each geriatric patient should not be able in less than 1 hour. This is the minimum time, sir, I tell you. Or at least they require 2 or 3 hours. I have worked with these persons. They have so many multiple problems, and this is one of the areas which can easily be neglected in view of their advancing age.
Yes, definitely. So thank you once again, and over to Dr. Aditi for the next presentation.
I would request Dr. Sheila ma'am to kindly
Aditi, you have to flash the slide, Raja. Yes. Then I'll invite sir. To be honest, till Aditi flashes sir's slide and I make a formal introduction, very honestly, for me, sir is one of the best teachers. And I love listening to him because I always learn something. Every time I listen to him, Even if he's talking on a topic which I've heard before, he's always adding something new, something innovative, and with such clarity of thought that the clarity makes you feel like, oh my God, how much you don't know. So a formal introduction following this for Sir Dr. Nihal Thomas, as we all know him. He's, of course, having more than 300 index publications. If I go on and on about his expertise, I think Nitin is going to tell me, please leave the meeting. But he has several chapters, 2 books, one in its 8th edition, Google Citation Index, 19,000 plus. Areas of interest involve the pathogenesis of diabetes in India, general endocrinology, 20 orations, projects to train medical and paramedical staff from 200 rural hospitals for diabetes, more than 70 multinational and in-house clinical trials in diabetes, initiated lab and basic science expertise for next generation sequencing in diabetes, indirect calorimetry, hyperinsulinemic clamp studies, body composition, and NMR spectroscopy. Extensive overseas network with several foreign universities, the Lord Yedanpalli Award for Outstanding Research in 2009, and the department was recognized by the BMJ for Diabetology Team of the Year 2015 and the Royal College of Physicians Award for Excellence in Teaching and Training 2017. Expected with you being at the helm of affairs, sir. So over to you. Looking forward to learning from you. Sir, you're muted.
Thank you, Dr. Shaila. And it's wonderful to be here at this particular forum. I've always thought that geriatrics is perhaps one of the most challenging specialties. And I do believe that the geriatric physicians themselves come to us for an endocrine posting. But I think it's high time we taught vice versa, because geriatricians have skills which are very unique. The interface between humanness and humanity with science is unparalleled. So this is a talk which I've been asked to give, and I think it's that the aspect of pragmatism that one really needs to focus on in handling patients with diabetes and geriatrics is the ultimate. Are my slides visible to you?
So you'll have to put it in slideshow. Yeah, it's now visible.
Sorry. Yep. Is that it?
No. Yes, sir. Now it's fine. Now it's fine.
So I'll be talking about a clinical approach to diabetes in the elderly. And as you can see over here, I mean, the best thing I'd like to do is when I reach my prime time in life, which is perhaps around 80, is to sit down and take care of my grandchildren and look comfortable and happy. And I would also like to be like the person on the left-hand side of the slide, which is indeed Gandhiji, who did the Dundee march in the year 1942 at the age of 72 years. And to have that degree of fitness at that age is something which I look forward to. So with a prelude, I will start. They say that wisdom comes when you are old. Your best years are yet to unfold. However, there'll be a decline in your vigor if you do not take care and control your sugar. So I'll be talking about these aspects: a patient case history, the baseline assessment, glycemic targets in the elderly, monitoring of glucose levels, oral antidiabetic agents, insulin aspects, and a little bit of self-assessment to provoke your intellect and a few take-home points. So this is an 85-year-old man, a former principal in a school, who was very independent till 4 years ago. He used to walk 4 kilometers, had diabetes of 20 years duration, was on premixed insulin with a pen, self-injecting along with glimepiride. But he never monitored his glucose values too well. His A1C was 9.6, above 9 most of the time. And over 2 years, he now had severe peripheral neuropathy and can only walk with a stick or a walker about 10 meters within the house. He has developed a coarse tremor of the right hand, has sleep disturbances and spends 3 hours of sleep at night, 8 hours from 10 a.m. to 4 p.m. during the day, has nocturia and wakes up 6 times at night, goes to the toilet despite reasonable normoglycemia, and lives
We lost him.
Yeah, I think we've lost him. So it is.
Yeah. I'll try and call sir.
Yeah.
Sir, can you hear us?
Hello, am I with you? Yes, I can hear. I'm with you.
So we lost you for some time. So you'll have to just
okay.
repeat everything, share your slides again and repeat.
That case history.
Fine.
Yeah, the case history.
So he has an inability to inject insulin due to the glycaemin
Oh,
due to dropping
we
of.
cannot see your slides, sir. You'll have to screen share. Yes, sir. Fine.
Yeah. So he cannot inject insulin with precision due to the tremor, has clumsiness leading to dropping of medications, and cannot fit needle or cartridge. There's trauma to the skin, which leads to lipohypertrophy, bleeding, and leaking of insulin. And he has inability to approach the refrigerator to get his insulin out. He feels very fatigued. He traumatizes his fingers in the process of glucose monitoring. Hence, he is phobic as far as monitoring is concerned. So this is an absolute real life case. A person whom I know and someone who has a huge amount of problems in handling his diabetes. You have to be absolutely pragmatic when handling these problems. So when you see a patient with diabetes who's elderly, you need to do a baseline assessment. And we all should know how to do a frailty assessment, which is a very simple tool to assess functions. And these icons make it very clear. You can grade a person from someone who's very fit, as in 1, to someone who's terminally ill, as in 9. And our patient over here was, in fact, quite well till 2 years back. And he had no active disease. But within a period of 2 years, he's become moderately frail. And so therefore, he needs help within the house. He can stay only within the house, and he may need assistance even with his basic activities of living. So we need to know how to handle such a patient, grade them appropriately, and then make decisions before we start treating them for any disease that they have. Cognitive dysfunction, as you heard beautifully in the previous lecture, increases with age and is associated with poor diabetes control. And unfortunately, many of these patients who grow older, who've had a robust life for many years, within a period of time, and because of that lack of brain volume that the Accord study showed, they have a lot of problems. They may forget to take insulin, oral anti-diabetic agents. Complex prescription should be avoided. Polypharmacy can be extremely difficult and hazardous to handle, maybe even dangerous. They significantly affect patients' ability to perform diabetes self-management tasks. So self-monitoring, making decisions about insulin dosage changes, they can all disappear into thin air. An insulin pen may be convenient to use, but then you cannot change. If you're using a syringe for many years and you expect an 80-year-old to change to a pen, it's going to be very difficult. Diabetes self-management often requires patients to learn new and sometimes complex skills. And this needs multiple episodes of education. A person who is young, a type 1 who's 14, can learn it in 2 sessions. This kind of a person may need 10 sessions to actually pick up something. Structured education on a one-to-one basis is required, and the physician himself may not have time or the inclination for repeated education. So you need an intermediary. You need a diabetes educator who's trained and is crucial for this kind of management. Depression can cause functional disability, negatively affects self-care. And screening for depression in adults with diabetes is very important. It coincides very often. Depression needs to be addressed before making any self-care changes. Make an assessment of physical disability. They have peripheral neuropathy, they have syncope, they may have postural drops in blood pressure. They're all there together. And this aspect can add to the aspect of handling self-care, which they can often not do. They need an additional caregiver, which may impose an additional financial burden, and they need to have modifications in their domestic environment by employing home helpers. They may have hearing loss, visual problems, once again affects insulin injections. They have fear of falls, which limits their exercise, and therefore managing diabetes in this is a major challenge. What are the glycemic targets? Well, the A1C targets have to be relaxed as you grow older. You're much more worried about damage caused by hypoglycemia, either to the brain through ischemia, recurrent episodes of ischemia. You can induce hypoglycemia and unawareness with recurrent episodes of hypoglycemia, and you can even precipitate a myocardial infarction or an arrhythmia with hypoglycemia. So if a person is fit for age, you can stick to the traditional targets. But by and large, once you cross the age of 60 or 65, you need to relax the targets. And therefore, this is where we are. 7.1 to 8% for those who are functionally dependent. And therefore, you need to be very careful and relax the targets. Tight control as you grow more senior is not really required. And once you reach the point of palliation, end of life, it's a reality, and you need to actually know to be pragmatic at that situation. Avoid symptomatic hyperglycemia or hypoglycemia. Don't worry about the A1C at that point of time. Okay, so the glycemic targets, according to the age and in older people, is relaxed, as I mentioned over here, and it shows you here. You can categorize them with frailty and also at the same time with dementia. And you combine the two together to make your decisions as far as A1C is concerned. And this is taken from the Canadian guidelines for management of diabetes in the elderly. Very useful algorithm to make your decisions. Your glucose cutoffs are higher. And once you have frailty or dementia, your fasting glucose could be anywhere in the range from 110 to 160. And your postprandial glycemia need to be less than 250 milligrams per deciliter. The comparison between the ADA, the Diabetes Canada, and the IDF guidelines are over here. And they can show you over here, once again, combining frailty with dementia and making your decisions. Also looking at other aspects of the blood pressure and tightening. So the measurements of blood pressure and the targets, once again, are relaxed. You need to be careful about postural hypotension in these people. So in older patients, the perception of hypoglycemia is extremely poor. As you grow older, the recognition of hypoglycemia, even without hypoglycemia unawareness, which is an entity beyond itself, is actually quite poor. And so you may not have any symptoms once the glucose levels drop to around 55 in most patients. You need to recognize this and you need to be prepared for it and tell all your patients that this is very important to recognize. The risk factors for hypoglycemia, as we all know, are also more common in the elderly. The GFR declines. Autonomic dysfunction is common, and they have cognitive impairment. They may have a non-alcoholic fatty liver disease in addition. And of course, to add to all things, poor habits with alcohol intake. Many of them may, in fact, silently take alcohol. And I have seen it in an Indian setting. You're not known to even take alcohol at all. But to have a good sleep at night, they take a peg of alcohol. And this is quite common nowadays. So how do we monitor these patients? We should use meters with large, bold displays with large numbers. Meters with a memory are very important and no coding. And the usage of continuous glucose monitoring systems has now come in as a very important management tool in our patients who are elderly. Here is an example, a 73-year-old retired gentleman with hypertension and hyperlipidemia, hypothyroidism, uncontrolled diabetes with a consistently high A1C, was on Novorapid thrice a day and Glycaemin at bedtime. Erratic dietary patterns, lipohypertrophy over the injection sites, taking fixed doses of insulin with no titration, required intensive monitoring with appropriate insulin dose adjustments. So we ran a continuous glucose monitoring on him, and this is just a few days ago where we took the recordings. You can see multiple episodes of hypoglycemia during the day, and this is basically a somogy which is occurring over here. And somogis are extremely common in patients who are elderly, totally unrecognized. and particularly those on premixed insulin. This is extremely common. We need to know about it, and if possible, change to a short-acting form of insulin is required. Another 73-year-old lady with visual problems, a retinal detachment on one side, laser treatment on the opposite side, and she also has bone pains in addition because of her previous surgery to the spine. She has recurrent admissions to the hospital with frequent low hypoglycemia, was on multiple medications and insulin. She's on, once again, on a basal bolus, the best that you can give to an elderly person. But you can see over here, once again, with continuous glucose monitoring, we have picked up multiple episodes of Somaghis, and you have valleys and peaks over here in the glucose monitoring. How do we handle it? And we analyze the entire problem. She lives alone with an elderly husband who is physically less competent than her. She has poor family support, a major problem which you're going to face in India. It's a big problem in the West, and we're going to have it more in this country. She's socially isolated. She does not meet her son very often, and she has poor vision. She tries to differentiate the insulin doses by the clicks of the pen, but even her hearing is impaired. Poor technique of insulin administration with insulin, needles being changed once in 10 days. Lipohypertrophy, very common and should be recognized in these patients. So what we did, we got the son in a big way. We spent 3 sessions with the son, got him involved in the care, used the FGMS continuously for long term. Thank goodness they could afford it, and multiple teleconsultations. With that, the sugars could be better controlled, and we in fact stopped the night dose of Glycaemin. Many elderly patients have a poor hepatic glucose storage. They're not like people like you and me. So they do not have glycogen in the liver, and you can stop the nocturnal dose of long-acting insulin. And with that, there's some sort of an improvement. There's a compromise here. The fasting glucose levels are high, but you can't do better. So you have second best as opposed to best for these patients. Next, oral anti-diabetic agents. What do? Metformin is the foundation. I don't deny that. I still think it's the foundation. But we need to understand that we need to have memory aids like pill containers with days marked on the containers. Ask the patient to bring the medications at every visit. They make mistakes. They will forget what you tell them. Bring the medications and get someone to explain to them how to take the medications and what exactly they are for. Give them cues, pictures, icons on the box. Involve the family members again. Metformin is the foundation. But the problem with metformin is as you grow older, you become more sarcopenic. You may lose more weight. And metformin might perpetuate that in a subset of patients. Not in everyone, but in a subset. The eGFR might decline silently, even without the creatinine showing a rise. And you need to be careful over there. When they get sick, they could get lactic acidosis occasionally. Thiazolidinones don't cause hypoglycemia, but they can cause weight gain. And in some people, it may be dramatic with the insulin requirements decreasing, but they may gain weight because of thiazolidinones. And they can become more prone for fluid retention. So you need to be very careful with thiazolidinones in elderly patients. I'm not saying don't use it, be cautious. Alpha glucosidase inhibitors, useful because they do not cause hypoglycemia, but they can cause bloating and flatulence. To add to the constipation that they have, this can be extremely unpleasant. So it may not be suitable in such patients. SGLT2 inhibitors definitely have an impact in patients who have volume overload, cardiac failure, early renal disease. But one of the things which I find is now nephrologists and cardiologists are using them a dime a dozen, even in the presence of urinary tract infections, even in the presence of prostatic disease, they're being used. Be very careful over here. Remember, elderly people are more prone for hyponatremia by itself. And you add on an SGLT2 inhibitor, they work on the proximal renal tubule, which can perpetuate hyponatremia and even hypokalemia. So if you have electrolyte imbalances, do not use SGLT2 inhibitors in these patients. Think carefully, customize your SGLT2 usage even in patients who have cardiac disease. Briefly with the others, DPP4 inhibitors, quite safe in elderly, low risk of hypoglycemia. If you want to use a sulfonylurea and if you're forced to use it because of more medications that are required, use gliclazide more often than glimepiride, and try not to use glibenclamide as far as possible. Meglitinides are an excellent choice after the DPP-4 inhibitors instead of sulfonylureas. They reduce the risk of hypoglycemia. Of course, you need to give them frequently, so the issue of polypharmacy does arise, but there is some evidence to show that they may be effective in elderly, and particularly those like the elderly man I described with poor eating habits. Finally, with insulin, do the clock test in them. You can predict who is likely to have problems with insulin therapy. Even if there's no frank cognitive dysfunction, even if there's no frank dementia, write the numbers on a blank clock face and draw the hands. Tell them to do this. And this is what you might end up with. They may be totally unsuitable for insulin in this situation. Simplify the insulin regimen. Change the pen devices for easy and accurate administration of insulin doses. Magnifiers to you read numbers or gradations on insulin delivery devices. Involve caregivers in supervision and administration of insulin if required. Titration of insulin doses based on self-glucose monitoring with precautions. You need to have the family members involved over here. And just mentioning to you, premixed insulin is convenient because it's twice a day, but then you're more likely to cause hypoglycemia because it's less flexible. Basal bolus is safer, but can you get the person to inject him or her 4 times a day if it's required? Conduct educational sessions slowly. Remember, a young person can pick up things in 10 minutes. An older person may take an hour. Schedule multiple sessions. Make sure patients understand how to identify hypoglycemia and treat them promptly. There's a tendency to forget or ignore hypoglycemia as you grow older. And finally, for those of you online, a few self-assessment questions. The most common concern with SGLT2 inhibitors in the elderly is pancreatitis, urinary tract congenital infections, thyroiditis, hypothyroidism. And the answer is B. Aging is associated with all except decline in beta cell function, reduction in blood insulin levels, increase in muscle mass, lack of physical activity. And the answer is C. Which of the following drugs are considered to be first-line agents in elderly with type 2 diabetes mellitus? Gliclazide, metformin, dapagliflozin, glargine. And the answer is A. Gliclazide, well, plus minus. Maybe metformin in some, maybe gliclazide in others. Which of the following factors must be considered in an elderly before initiating insulin? Visual acuity, cognition, manual dexterity, all of the above. You have to look at all these 3 aspects while planning for giving insulin to a patient or self-administration is required. So here is a checklist. Assess the level of functionality in all your patients in diabetes in the elderly. Individualize glycemic targets based on the A1C. Avoid hypoglycemia in cognitive impairment. Well, avoid hypoglycemia in anyone. Select anti-hypoglycemic therapy carefully. Caution with sulfonylureas or thiazolidinediones. DPP-4 inhibitors should be used over sulfonylureas. Caution the SGLT2 inhibitors are those with the prostate, UTIs, or bladder neuropathy. Basal analogs instead of NPH or human 3070 if possible. Use continuous monitoring devices where possible. And give regular diets instead of diabetic diets or nutritional formulation as you grow older. Thank you for your patient insulin.
Thank you very much, sir. And I reiterate what I said, we always learn. And I'm sure all of us are going to keep that checklist with us, because along with everything else that you taught us, you also taught us the importance of being empathetic towards the patient who is sitting in your consulting, which often we are all guilty of not being. To take this further, Aditi will take the question answers from the chat box.
Yes, ma'am. So it's my privilege to invite Dr. Jubin Jacob, sir, to take over the question answer session, sir. We welcome you, sir.
Aditi, I can't see Jubin.
Yeah, I think Jubin is still to join, so maybe we can still go ahead. So, yeah.
Right.
The first question is by Dr. Arvind. I think we could take this to Dr. Prem, And Arvind is asking, Dr. Arvind is asking you, Dr. Prem, that if not BMD, then what we should use to assess osteoporosis risk in diabetes? And another correlate of the question is the calcium requirement different in patients with diabetes?
Actually, what I was trying to say is BMD might not tell us the exact risk. There might be more risk than actually happening. So BMD should be done anyways, but it can be done with a trabecular bone score. If there is a suspicion of, obviously in a diabetic, that there is a high fracture risk suspicion, because see, the thing in older adults, as I mean, first of all, I would want to say, I think there's an excellent talk by Nihal sir. I think I'm just still thinking about that. So the thing is, that in older adults, you have to be very, very clear in not missing those small things, because a fracture can cause so many issues later that the quality of life will be completely compromised. That is one. Secondly, no, the calcium requirement does not different. It's not different. You can give the same calcium value.
Dr. Pankaj, you want to ask the next question?
Yes, this is from Dr. Navya Shruti. Is therapeutic, this question is for probably Dr. Ravikant. Is therapeutic benefit for dementia different in diabetic versus non-diabetic? So probably she wants to ask that whether response to therapy for dementia is different. Dr. Ravikant, are you there?
Is there?
Dr. Ravikant, please, can you hear me? Okay, probably
we'll go on to the third question. I'll call Dr. Ravikant.
Can I chip in on that one, which was actually not meant for me? I think perhaps a few points which I probably raised is the fact is that once you do have cognitive decline, obviously you need a lot of support, caregiver support, which is the primary thing. And I guess the other aspect is you need to relax your glycemic targets as far as the A1C and even the day-to-day glucose monitoring. So I think these are the two primary things, and of course, making things as simple as possible.
Probably the notion is about treatment of dementia. So dementia, the response to therapy is different between diabetic and non-diabetic. What I think so is in diabetes with lots and lots of micro and macrovascular complications, there might be some additional ischemic changes, and which may reduce response to therapy in those cases. So your take on this thing?
Yeah. Although there is hardly any literature in diabetic versus non-diabetics, but yes, of course, this is in our clinical practice that we have observed, because these patients of diabetes mellitus with multiple comorbidities, they have concomitant depression or some other neuropsychiatric disturbances. So in a sense, they do fare not that well as compared to non-diabetics. But yes, of course, we need to have some head-to-head comparison. That is something which can be explored. But yes, in our practice, we have seen that the response is not that great in diabetic population so far as treatment of dementia is concerned. The only thing that we have in our hand, if we are careful about the preventive aspect of developing certain diseases which are specific for geriatric age group, and we identify them early, then really we can think that yes, of course, we can treat them in a much more effective manner. And most of these things like disease like hypothyroidism, like depression, like polypharmacy, they needs to be looked into very carefully if we really want to impress upon the effective treatment, not only I say dementia, but in fact to any other disease.
So after all, everything comes back to overall comprehensive control of diabetes.
Comprehensive control
from the very beginning.
And assessment of this geriatric age population.
I'm not finding any other question in the chat box.
There is one more question to Sir Thomas. Sir, there is a question that do you have any insulin preference in the elderly?
Yeah, thank you. That's a really good question, because I think the fact is, I would like to highlight that it's more important about how you give your insulin and how you, space out the calories in between. That should be considered first. The issue about balancing the diet, the challenges, of course, of giving intermediate snacks when you have a person who's irregular and not being able to do, these have to be handled first. Once you have handled that and you still have hypoglycemia with the regular forms of insulin, and then if the patient, of course, can afford to go in for other forms of analogs, that would be the next step. So I think you need to work on your diet and your physical activity first, then make changes in the type of insulin which is being given. So certainly the aspart would have an advantage over soluble insulin. Fiasp would have a further advantage over aspart. So that's what you could actually. I also mentioned the fact that over and above NPH, I think it's okay. It's better to use glargine, certainly, if you're going to be using a basal bolus regimen. The other point is that there are many elderly people who may just manage with, because of concomitant subtle gastroparesis, and also the fact that they have a poor glycogen storage. You'll have people who even manage with one short acting with breakfast, another short acting with dinner, and nothing else in between. You have all kinds of peculiarities. So you have to actually work on the individual patient and see what the pattern of glucose is, and then make your decisions as far as insulin adjustments are required.
Yeah, I would like to add one thing here, that whenever we are using glargine, the conventional way is to use this thing at bedtime, or at least in the night time, with or after dinner. But since it also has a significant peak, which may lead to early morning or late night, midnight hypoglycemia, so probably it's prudent to use this long-acting insulins in morning hours, so that there is a peak which is coming in day hours, which may coincide with the lunchtime, and the lowest part, the trough portion, is coming in midnight, and which may reduce chances of midnight hypoglycemia. So in elderly individuals, using long-acting insulin in morning hours, though it may need a 5 to 10% extra dose, but probably it may be a rescue from the risk of midnight hypo to a certain extent.
I agree with you. And I think one thing you beautifully highlighted is that large.
Can you please repeat once again? The connection was lost.
I think sir is still having poor connection.
What would have happened is in CMC campus, once the light goes off, when it comes back again, the connection goes off. So that's the problem.
So can we hear some expert comments from Dr. Vinod Kumar on these aspects? The ability person.
Okay, thank you very much.
I'm sorry. I think I disappeared in between.
I think you are all so much expert, and you have dealt with the subject so beautifully well. I was actually hopping in and out because I am at the moment attending a diabetes conference also. So I didn't really listen much about what you all spoke, but I just, I think I have listened some beautiful ideas. And Dr. Pankaj Agarwal, who was emphasizing about the use of giving long-acting insulin in the morning for elderly people, I think is a laudable idea, and it is worth considering very seriously. I think I would just make a general comment that these patients of diabetes who have, say, dementia, for that matter, they have osteoporosis and its consequences like widespread arthritis or fractures not operated, and the patient becomes bedridden. Patients with dementia, finally, they become bedridden. They all need caregivers. And I think you must have all talked about the importance of caregivers in giving care to dementia patients, to diabetic patients in their last stages, particularly if they are associated with life-threatening chronic conditions like dementia and frailty and so on. You must have discussed. I partly listened. You have discussed. So I would just like to inform you that There is a act in the from the Parliament that's called Maintenance of Welfare of Senior Citizens. To be more exactly, it is called Maintenance of Parents and Welfare, Maintenance and Welfare of Parents and Senior Citizens Act. And we were asked recently to lay down the specification, standardization, and rules under which these standardization could be followed for giving home care facility and for giving hospice care facility for people who are having irreversible terminal illnesses like dementia or chronic obstructive pulmonary disease or cancer, and they may also happen to have diabetes by the side. And diabetes it promotes dementia. It also promotes many other diseases. So I think diabetes could be an integral part of many of these life-limiting diseases. So I just wanted to share with you that the government is interested in finding out the specification standardization for giving home care to such patients and for giving hospice care to such patients. And I think the calculations indicate there are about 6 million people who require the home care or hospice care. They are lying bedridden. They are not looked after. Some of them do not have even a caregiver. So I think it is a much larger issue. And to the best of my knowledge, these rules and regulations about hospice care and home care as a part of the package under the maintenance of and welfare of parents, senior citizens. I think this is going to the this winter session of this parliament. And let us hope that hitherto so far neglected segment of population of terminal illnesses, including dementia, and they may all be associated with diabetes. Let's hope that these terminal illnesses, which as doctors we are not much tuned or much trained in looking after. So maybe the judicial approach to the caring of these bedridden people would do something good for the country. Thank you very much.
Nihal, can you continue from where we were lost?
I'm sorry. So the fact is that, I was talking about customized treatment, which is so important. And I was basically saying that short-acting insulins in some patients, maybe even twice a day in some patients who are elderly. So that's important. And yes, like you said very rightly, that there's no such thing as a truly peakless insulin, even though, in literature and perhaps the industry keeps talking about it, glargine does have a peak. And even Digludec, for that matter, does have some degree of a peak. In fact, despite it having perhaps a little lower nocturnal hypoglycemia than glargine, the other thing you need to worry in those who are really elderly is with the declining GFR, the potential of stacking with Digludec is more. So accumulative. And once again, it's customized. One person may do extremely well with Digludec, but someone else may in fact have a stacking effect. So choose your patient, study the profile, and don't assume that an adverse effect does not occur.
Thank you.
Aditi, I don't think we have any further questions, so can we hand it over back to you?
Yes, ma'am. Thank you so much for taking all the question answer sessions, sir and ma'am. Now coming towards the end of the scientific session today, but it's my privilege to invite now Dr. Sanjay Kalra, sir. Sir, for your concluding remarks on today's session, sir, please be welcome you. Over to you, sir.
Thank you, Aditi. Today is a special day because this is the last in our series of webinars on geriatric endocrinology for this year. When we began this series, we thought that we are the first people in the world to do it. But then Dr. Vinod Kumar, sir, who has been past president of the Endocrine Society of India, he very kindly told me that around 45 years ago, they had an international conference on endocrinology of the aging in New Delhi. So this is actually an old is gold kind of a topic. The topic of geriatric endocrinology has certainly achieved midlife maturity because it is almost 50 years old in India, thanks to the pioneering efforts of Dr. Vinod Kumar. But instead, in spite of this midlife maturity, it continues to exude what we call maiden charm. And that maiden charm has been made possible by all our speakers. Today, especially by Dr. Prem, Dr. Nihal Thomas, and Dr. Ravi Kant. So I'd like to thank all of them for having helped us in this journey of understanding and learning about geriatric endocrinology. Another beautiful thing is the interaction that we have with each other. Geriatricians, internal physicians, endocrinologists, everybody working together towards a common goal. And that goal is good health for all our senior citizens. I'd like to take the opportunity to thank all our patrons. Dr. Vinod Kumar sir is with us, but also Dr. A.B. Dey and Dr. Meenakshi Dhar. Dr. Ganpati Bantwal is with us, and Dr. Rakesh Sahay. This is the last of this year's webinars, but I think on behalf of all of us, I would like to request the Endocrine Society of India to continue this activity next year. We'll request Dr. Ganpati Bantwal to talk to us about that. And I'd also like to request everybody who has logged in today to continue this process, this journey of learning with us. It feels good when we work together. And of course, Dr. Nitin, Dr. Pankaj Agarwal, and Dr. Shaila Sheikh have been instrumental in carrying this forward. Thanks to you as well. So, Dr. Ganpati, you are the president of the Endocrine Society of India. What plans do you have for us next year?
I think Rakesh will be taking over. I've actually spoken with him regarding this, and Dr. Vinod Kumar sir told still some topics left, and there are others who want to take part in this. I think we'll go ahead with this. I've spoken with Rakesh already, the next president. I think this has been a very good, a webinar series. Short and sweet, I would say. Good, very important topics, and nicely done. I would actually congratulate Nitin and Jupin for making this. I want them once again to lead that team once again for the next year also. Sir, any other topics, burning topics, you can actually send us. We will try to incorporate it, sir.
And we'll request Dr. Nihal, Dr. Ravi Kant also to contribute, Dr. Pankaj Agarwal. And Aditi, thanks for moderating this session. Thanks for taking care of all of us today. So on behalf of Dr. Ganpati, Dr. Rakesh Sai, and myself, I'd like to thank all of you. Dr. Shaila, Dr. Aditi, and the floor is yours.
I just want to say one thing, if you permit, and that is that there are, as you already pointed out, there are some speakers left out and there are some topics left out. So we could go ahead as Dr. Bantwal has permitted to do that, and he would be talking to the next president, Dr. Rakesh Sahay. And I think this may continue. We have no intention of invading into other spheres, but I have at the back of my mind, I would like to, if given a chance, I would like to hold such seminars on geriatric nephrology, geriatric cardiology, geriatric psychiatry, geriatric neurology. So far, we have invaded on the endocrinology. Thank you so much.
Thank you so much, sir. And I think it was a great session today. We had a wonderful scientific session, and I would want to thank our chairpersons, Dr. Shaila Sheikh ma'am and Dr. Pankaj Agarwal sir, and to all our esteemed faculty members for the lovely session. Thank you to Dr. Vinod Kumar sir, Sanjay Kalra sir, Dr. Ganpati, and Dr. Nitin Kapoor sir. And I think if there are no more comments, we can close the session. And thank you so much for joining in.
Goodbye.
Thank you to all our delegates. Thank you.
Bye-bye.
Good.